of nurses, like a lot of people in nursing, I thought that I knew a fair amount about your specialty, and as I said, I've had to go through a period of re-education, really getting a much better feel. With that, maybe a caveat that if I say anything just shockingly ignorant, correct me gently. But want to talk about a few things, and sort of part of the theme and what I want to address is again, establishing your voice, asserting your value. So in the sense of a process that you've been going through, identifying who you are, what you do, really relating a lot to the idea of self-regulation that I think is important in any profession, of defining the parameters of your own practice and within your own specialty. Talk within that about advocacy as well, and then looking at value and sort of how we look at within nursing and within your specialty, economic, which is a major focus here, and otherwise, as you'll hear me talk about, and look at how these are related. So a lot of what I'll talk about really are issues that relate to nursing as a profession, to nursing broadly, but also look at how these relate to the specialty of clinical research nursing, but be patient. If it doesn't seem like I'm getting to that, I will. What I promise you is not an hour-long talk on economics. I think that should be a relief to most of you, but really a lot of what I want to talk about are issues that are really fundamental to nursing, and I think at the core of your specialty as well. So when we talk about a voice for a profession or for a specialty, really forming an organization really is a fundamental aspect, a fundamental step for whether you're talking about a profession or for a specialty. And clearly you've done that, you've been doing much of the hard work. I know how difficult it is to come together and then to do the work of building and sustaining an organization, and you've been doing that very significantly and very impressively. As I said, defining who you are, what you do, the ability to speak for yourselves, to have your own voice, is significant there too. But you've joined a somewhat crowded field in doing so. Let me see if... So not to put too fine a point on it, but as you know, there are many nursing organizations out there speaking either for the profession as a whole or speaking for aspects, specialties within that profession. You're also seeing an example of my obsessive-compulsive disorder. I don't usually reveal it that quickly, and as I say, it's not a complete list. So a question really to ask is, well, what do you have to add given this large number of organizations out there? And again, defining who you are, what you do, the opportunity to speak for yourselves within the profession, a very important aspect of that, but also with your professional colleagues outside of nursing in a variety of disciplines, speaking within healthcare systems and organizations, and within and to industry. And emphasizing, I think, your unique role in research and the research enterprise, and the role that you take in improving care for patients and for populations, educating about your specialty, which I think is key for many people that don't really understand what it is that you do, and looking at strategies for getting that through, and again, strategizing how to move forward, and emphasizing, as I'll talk about, what your contributions are to the nursing profession. In terms of advocacy and what an organization can do, it's really, as we've all, as nurses through nursing school and graduate school, wherever we may have been in our careers, had it drummed through our heads, I think quite appropriately, that we serve as advocates, as individual nurses serve as advocates for patients, but looking at a broad scale of what can be done beyond that individual level and even beyond individual systems and healthcare organizations, being able to speak collectively on some of those issues and being much more effective on that broad scale as an organization. The work that I know you've been doing on scope and standards, which is so key, a part of defining yourselves as a specialty, and I know you've made significant headway, significant progress with that. And again, addressing some of the broader issues that affect your specialty, affect the subjects, the patients that you work with, looking at some of the policy issues that affect your specialty and your patients, and as well as issues in practice and research, and developing an agenda. I know you've done substantial work on a strategic plan and continuing to do that. So looking at your perspectives, your future, but also how that influences where nursing is going, how nursing sees itself, what kinds of priorities get set. In looking at issues of economic value and including nursing as a whole and within your specialty, one of the things that I will say now, you'll hear me repeat it one way or the other. Trust me, it's a planned redundancy, but that I think it's crucial to be looking at that. We will be looking at that, but that in many ways it's only part of the story. It's only part of what needs to be looked at in terms of value of nursing. One important sort of foundational definition of what nursing is, I won't read this out loud because I know you all have this memorized, but again, going back to basics in a sense in terms of what nursing is about. And I won't leave it up there. Part of this idea also in terms of really any profession that serves the public, and certainly true for nursing, we often talk about nursing's social contract. And it's the idea that we're given the privilege of practicing and of working with patients, of practicing a profession, but that there's an exchange there, that as part of that privilege and that authority, that there are obligations to society. So to patients, sort of thought of broadly, whether individuals, families, communities, populations, society as a whole, but that there are obligations that we carry out. And inherent, sort of basic to the concept of a contract, any kind of a contract, is that you're looking at an exchange of items or services, but of things that have value. That's, again, for any kind of contract that might be out there. So basic to the idea of saying that nurses have a social contract is the idea that we perform services that have value. In looking at that social value, I think it's a starting point for looking at the value that nursing brings. Again, the IOM, I shouldn't say again, just meaning again, here you have a long quote. The Institute of Medicine, when it did its report on the future of nursing, really, I think, did many important things, but I think in really identifying here in what you see in front of you, a strong sense of what it is that nursing brings to patient care, and a broader view about not just those individual patient encounters, but really who we are, where we're situated in terms of changing how care is delivered. Let me just 1 second for this awkward sip of water here. So again, looking at economic value, emphasizing that it's important, but really only one aspect of looking at the value that we bring, and urging you, as we talk about this, to keep it in context. Part of that context is in looking at costs of healthcare as an increasing and continuing area of concern nationally and really internationally in most healthcare systems. I won't sort of overemphasize figures. I think you've heard many sort of similar figures, but just the massive amount of money that is spent in this country and others on healthcare, that most recent figures out there, an average of over $8,000 per capita spent on healthcare, and the share of the gross domestic product and how dramatically that's devoted to healthcare, how dramatically that's increased. It's a story that most of you have heard, even if the specific figures don't always come to mind, and just one illustration of that. from 1960 to 2010, just again, I don't think this is news, but this continuing increase. And what you often hear people talk about in looking at issues of cost and trying to control costs is this concept that's referred to as bending the cost curve. So the idea being of the main goal not necessarily being reducing overall cost and overall spending, but trying to reduce how quickly those costs are going up, reducing that rate of increase. So that idea of bending the curve. That increase, the rate of that increase actually has slowed over the past few years, estimated at around 4%, much lower rate. There is some debate as to whether that's due to some of the measures that are in the Affordable Care Act, or whether it's been related to the slowdown in the economy and slow recovery from that. But at any rate, at least for the time being, that has slowed. But this continues to be an important and a major issue and a major area of focus. I won't literally, well, I will ask it, but I'll probably answer it too. When we look at healthcare reform and look at the Affordable Care Act, and I think that if you asked, if I were to ask most of you in this room, most nurses, most health professionals, what are the goals of reforming the healthcare system? And I think an appropriate answer would be to say, really how it potentially and how it is and can continue to change care. So people's access to coverage, eventually access to care, looking more and more at prevention, looking at increasing access to primary care, increasing coordination, decreasing fragmentation in care, having more integrated care. I think those are all reasonable answers. Those are some of the answers that I would give. But if you think back to some of the main policy debates that took place around the Affordable Care Act, what people emphasized was the idea of getting a handle on healthcare costs, on reducing that rate of increase, at looking at doing these things, but doing them in at least a cost-neutral way. And again, much of that necessary for political and policy reasons. But even when we look at sort of what many of us might see as really important and substantive goals in terms of improving care, often the dialogue sort of shifts in terms of how to characterize that, and often those issues of cost get emphasized beyond these other goals. And so we see, without going into detail, at many levels, efforts that continue to get a handle on costs in terms of federal policy, the Affordable Care Act, but also budget issues at the federal and state level, looking at changes in the economy, what hospitals, other healthcare organizations are trying to deal with in terms of their own financial pressures, payers of healthcare and so on, but basically adding up to, from a number of different dimensions, continued efforts to control costs. And not to put too fine a point on it, but obviously the work that you do, the work that we do, costs money. It costs money to educate nurses. It costs money to recruit nurses to healthcare organizations, to look at measures to retain them, whether through pay, benefits, improvements in the work environment, and so on. And who pays for that? Employers certainly do, state and federal governments, whether it's through programs to support the nursing workforce or through in their roles as payers for Medicare, Medicaid, and ultimately, of course, payers of healthcare and any consumer in terms of part of what is reflected in our own costs in paying for healthcare. At the same time, nursing generates value, and I'll go into detail on that very shortly. Why should this be an issue? Why should this be a source of concern in terms of looking at economic value, trying to identify the economic value that, that nursing brings to healthcare? As I said, cost pressures on the healthcare system as decisions are made at various levels by government, by employers, by payers of healthcare, to the extent that we're able to identify and quantify, and I'll emphasize the where possible part, but where that can be done, where we can identify the value that we bring, it can help to support more informed, more evidence-based, and balanced decision-making about what kinds of resources get devoted to nursing care. Again, that can't be the sole focus. And one thing that I want to emphasize, which may, in some ways I think is a different message than some people expect to hear, but that in a healthcare system that is increasingly focused on issues of cost and focused on dollars and cents, and needs to be in many ways, nursing remains a humanizing factor in that system, that nursing focuses on human needs, and that understanding that and sort of moving from that, what I like to emphasize is that looking at those issues of economic value, identifying the value that we bring, quantifying it where possible, that really that's a tool, that it's not the goal. The goal isn't necessarily to save money for the healthcare system, not that that's a bad thing, but that to the extent that we can identify where that takes place, it's a tool that lets us advocate more effectively for better patient care, for decisions that can improve care, that can improve quality. So again, using that sort of as a support for advocacy efforts at various levels to improve care. But again, this only makes sense if we look at nursing's value in the broader sense. Now, one thing that my students are used to me doing, none of you would know this yet, is that I do like to digress a little bit into history. I actually think sometimes there are lessons to be learned from things that have happened before. Very early in the history of nursing in this country, at a time when nursing schools began to grow, and at that point, almost all of them based in hospitals. And there, as many of you know, sort of in those days with those old diploma schools, that nursing students provided the bulk of hands-on care, the bulk of patient care in hospitals. As I'll talk about, many people would characterize that as cheap labor or free labor. But as this was sort of being looked at, the hospitals early on were saying, well, no, this isn't a matter of us sort of getting something for nothing, because these are students, they're learning a skill, they're learning a profession, and basically this is a trade-off. This labor that they're doing is the equivalent of somebody paying tuition to go to school. So that was sort of the theme there. But early on, one of the early prominent nursing leaders, Mary Adelaide Nutting, said no in a sort of what was then a prominent address that she gave and continued to write on this and write about this. It was like, no, it's not the equivalent of tuition. It's really a financial windfall for the hospitals. Said it creates this sort of a perverse or misplaced financial incentives. And so while people might have looked at this huge proliferation in opening new nursing schools and said, well, this is great, and building the profession and training and educating new nurses and making sure that there is, skilled professionals providing patient care, that might be one way to look at it. But from the point of view of many, not all, hospitals that were opening these schools, basically the motivation was getting this cheap or free labor, and then emphasizing, well, the other thing was then part of that, sort of those perverse incentives, was it also meant that when people graduated from nursing school, very few of them found jobs in hospitals. Hospitals didn't need them because they were getting most of the patient care provided by students and who didn't command a salary. So she actually advocated looking at other ways of funding education, eventually moving education out of the hospital setting. But one of the things I think this helps to illustrate also is that a lot of these issues of cost and value often can look very different from different perspectives. And what might seem like a sort of a reasonable economic equation from one perspective seemed fairly outrageous or at least harmful from another. One of the ways that, certainly not the entire way, but one of the ways often that society places a value or signifies what kind of value it puts on work or on professional practice is how people are paid, what kind of a salary or wage they command. Again, one measure, not the exclusive measure. As nurses, as the location of where nursing was provided began to shift more and more into the hospitals, there was a great deal of concern about how low people were being paid. Looked at how to address this. The American Nurses Association, back in the 40s, or so they tell me, I wasn't actually there at the time, created, despite what you may have heard, initiated an economic security program and looked at a number of different ways of trying to address this. And one of the things they did was to, a little bit later, but to do a survey of what nurses were making, what other occupations were making. They looked at, this is one of the figures that was thrown out, that nurses were making substantially less than other employees, often other employees without a professional education, and then basically made this argument, and again, when we think about value, that nurses' salaries should reflect the value of their service to society, so linking those again, and then proposed the national salary goal for new RNs of $6,500 a year, which I think a threshold that we eventually met. So, over the years, now I say for the past 3 decades, and you could say it goes beyond that, but especially for the past 3 decades, an ongoing issue in many different contexts has been as hospitals go through changes in how they're paid by payers, what the impact has been on nursing, often resulting in sort of a short-term attempt to save money by cutting the use of nurses. And really prompting the profession to try to look at demonstrating the value that nursing actually contributes. So now I actually do remember this, but some of you may also. But when Medicare went through a major change in how it pays for inpatient care and introduced the prospective payment system that's still with us in one or another form today, moving from the idea of paying based on what care was provided or what the specific charges and costs were for care, to looking at a prospective rate. So as many of you know, looking at what diagnostic group a patient falls into determines what Medicare will pay. It was a very big change at that time because in the old days, hospitals would get paid based on the specific services provided to a patient. So whatever the intensity of care might have been for that patient, how many days they spent in the hospital, that was reflected in what hospitals would be paid. So one of the big changes was that if you had a given patient who needed more nursing care, needed more time in the hospital, those extra resources that you might put in to their nursing care wouldn't be reflected in how much they were paid. So there was really not only not a financial incentive to provide more care, there was really a disincentive. So the idea was that nurses would be seen as having an impact on the hospital's costs, but not on its revenues, at least not, as I said, not directly. There are obviously different ways of looking at this, but in terms of a strict balance sheet, again, bringing in more nursing care, staffing at a higher level in terms of skill mix, whatever, wouldn't result in any increased payment, just in increased cost. And so initially, when this then new system came into play, many hospitals reacted, many hospitals panicked, which they sometimes do, and many, not all, but reduced their use of RNs. And I remember this was shortly after I graduated from nursing school, during a time when I graduated of a great shortage, and suddenly we were hearing about nurses being laid off or hospitals freezing their positions, and it was just a very, very sudden shift. But it didn't last very long. Very, very quickly, hospitals turned that around, because one of the things that they found, or the major thing that they found, was that with this new system, the key to survival, the key to doing well financially within this system of prospective payment was being able to decrease length of stay, to be able to successfully get patients out of the hospital as quickly as reasonable, and that couldn't be done without sufficient nursing staff, that the kind of critical thinking, the kind of quick reaction of assessing patients' needs, of educating patients and families from the beginning about what their care would be, what they would need going home, couldn't be done by non-professionals or by paraprofessionals. And in fact, it ushered in a period after that of a very significant nursing shortage. So again, sometimes it's a matter of perspective and sometimes it's a matter of learning that what might have seemed obvious, nurses are expensive, so let's cut them because we'll save money, isn't always accurate. When managed care payment systems sort of took hold, again, hospitals, many of them were concerned, began looking at their labor budgets, looking at RNs as expensive, a period of workplace restructuring, reducing use of nurses, often replacing them with unlicensed personnel. And there was a lot of concern at that point that ANA and many other nursing organizations saying, well, this is going to have an adverse impact on patient care, on the quality of patient care, on patient safety. But there wasn't a lot of research at that point. There hadn't been a lot of work done that would actually demonstrate that there was a link between nursing care and patient outcomes, patient quality, patient safety. And so often the response, I still remember this is when I was on staff at ANA a couple of decades ago, and going to one prominent policymaker, the head of a significant federal agency, and when we presented these concerns, his question was, well, where's your data? And we just sort of, looked down at the table because there really wasn't a lot. The Institute of Medicine convened a panel to look at this, nurse staffing in hospitals and nursing homes and what the impact was. And again, reached the conclusion that with hospitals, well, they said we've been hearing a lot from nurses about their concerns about what they say they're seeing, but in terms of any kind of systematic collection of data, analysis of data about what impact this actually makes, and they even said, we tend to think that what you're telling us is true, and we've been hearing about it from so many people, but you really need to start that work of systematically collecting and analyzing that data, and that ushered in a real effort by ANA and then by many prominent nursing researchers to look at this and to be able to demonstrate that value, that impact that nursing would have on patient outcomes. And I won't go into each and every one of those, but just to say that since that time, there's been a large and actually body of research that's continued to grow that points toward the idea that staffing has a positive impact on patient care, especially in preventing adverse outcomes, reducing complications, nosocomial infections, and so on. Now, so one question to be asked is, what is that link? If you want to say that positive patient outcomes, that higher quality care, how does that relate to economic value? How do you link quality and cost? And a decade or so ago, a number of authors, Sheila Leatherman, Donald Berwick was one of the authors of a very significant article in the journal Health Affairs that looked at what they called the business case for quality. And they looked at sort of how you can look at the different cases to be made for different quality-oriented interventions from a few different ways. So the business case, when you have a healthcare organization that puts money into a quality-related intervention and that they see a financial return from that. So identifying that they've reduced costs or that they've avoided some financial losses, that they've increased their return or their profit, and that's within a reasonable amount of time. Obviously, that's a fudge word. Reasonable to one person may not be to the other, but for the organization, if they see that that return comes within a reasonable amount of time. Differentiate that from what they called an economic case, where you might look at an intervention that does save money or does have some economic benefit, but it may not be the people or the organization that puts in that investment that actually sees that return. One example would be if you have a hospital, let's say, that opens up a smoking cessation, a community-oriented smoking cessation program. Let's say it's very successful in bringing people in, getting people to stop smoking, and you and I could look at that and say, well, think about what is being saved in terms of reduced rates of COPD, reduced rates of lung cancer, general increase in quality of life, and all that would be true. And there would be some cost savings involved, but that hospital could turn around and say, well, that's great, but we're not the ones saving the money. In fact, maybe they could even say, well, we're getting fewer patients as a result. The insurers may be benefiting from that. They're not paying for the expensive care that would be associated with tobacco use. The individuals involved may be saving money. That's not a bad thing, but from the hospital's point of view, sort of, is there a financial incentive, an economic incentive to conduct a program or maintain a program like that? And then the other category that they looked at is a social case, where you might look at an intervention that actually does result in a better experience for the patient, in improved health, reducing suffering, and increasing their quality of life, but where you can't point to a clear economic benefit. So in looking at those three categories, and I actually think that's a really helpful framework, you could say, well, each of those is a good thing. In each of those, you're saving money and or you're increasing individuals' quality of life, reducing suffering. But there, again, in this article, the authors argued there's a limited incentive for an organization, a healthcare organization, to spend money on something that's going to improve quality if they don't see that they're going to obtain some kind of an economic return, an economic benefit, again, in a reasonable amount of time. And you see that the argument that was made at that point, that without being able to make that business case, that they felt it was unlikely that, at least in the private sector, that there'd be quick movement to reliably and widely adopt proven quality improvements. So hold that thought for a minute. Article that came out a while ago, but I think is still relevant. Jack Needleman and his colleagues tried to look, well, didn't just try, they did look at that concept of the business, and economic, and social cases, and how that might apply to nurse staffing, and looking at linking the outcomes that are associated with better nursing care to the economic impact on hospitals. And you see they compare those hospitals with better and worse or lower nurse staffing. And they said, well, yeah, there is a cost savings from reduced complications, reduced length of stay, when you increase the proportion of RNs in the overall nursing staff. So when you increase skill mix, so that there is a net savings that they were able to demonstrate. They said, if you just increase RN staffing or just increase overall staffing, so adding FTEs as opposed to just shifting the skill mix, from the data that they looked at, they said, well, actually, there's a little bit of a cost increase, not a significant increase, but a modest one. So one of the questions that might come up if you're sort of hyper-focusing on this issue of economic value is to say, oh, well, wait a minute, this is no good. We're not showing a cost savings, so like, can we really advocate for this? And what I would say is that's not what it tells you. It actually tells you a couple of things. One is you could make the argument, and depending on who your audience is, how receptive they might be, but you could say, well, we're not showing a cost reduction, and it's not cost neutral, but it's a really modest increase. And look at what we're getting in exchange for that, in terms of patients' quality of life, in terms of patients' overall well-being. And again, whether that's a successful argument or not depends on the context. But I think the idea is not to shy away from still advocating for measures that you know improve patient care. And in this case, saying a 1.5% cost increase is very different than saying it was a 70 or 80% cost increase. So again, you could even argue it doesn't cost as much as you think it does. But again, looking at a more nuanced argument and not just focusing only on saying, well, we can only address the things where we know that we save money. Another study that was done a little bit more recently that had been commissioned by ANA looked at economic value of nursing. You see just where they got their data from, both secondary data set and some of the prior studies that had looked at relations of staffing and outcomes, and tried to quantify that. So looking overall at savings in terms of healthcare costs, but also linking lives saved and disability prevented to national productivity, arguing that, well, if you have people able to return to work earlier or people who survive and return to work, that has an impact on the economy as well. And you see what some of their findings are there. But again, that attempt using very large data sets to look at, again, a broader view perhaps. In some ways it may beg the question of, strictly speaking, that business case, but at least an attempt to say, look, this is some of the economic value that nursing brings. I guess it's significant that they looked at these massive savings before labor costs. Obviously, that would sort of balance things out a little bit. But again, linking what nurses do, what nurses bring to patient care with that idea of economic value. But I think it poses a couple of questions. With all of these ways of looking at value, how much value do you include in that equation on reducing suffering, on improving quality of life, on saving lives? And again, perhaps it sounds naive sometimes, I hope it doesn't, but recognizing that as nurses, we do see a value in doing those things, and recognizing also that some economic benefits are harder to quantify than others, and some won't easily translate into economic terms at all. Quality of life issues, in some ways yes, in some ways no, but overall, even if you can't do that, even if there isn't a clear path to sort of demonstrating a cost savings around that, and also, as I said, looking at who receives the economic benefits, but still looking at the importance of that in terms of patient care. So again, you've heard me say it at least twice, that focus on cost and savings are important, but in this case, when we look at value, the question that's asked really is, what are we getting for what we're paying? So not just an issue of, gee, we're spending a lot of money on care, but sort of as the focus has shifted to value, it's what are you getting in exchange for all of that? So that increasing focus on value that's defined by many as value being outcomes relative to costs. As many of you know, Medicare has, for a few years now, initiated a program sort of under the general rubric of value-based purchasing, formerly known as pay for performance. Medicare has done this, many private payers instituting aspects of this as well, and saying, okay, well, we're going to pay an additional amount to healthcare facilities or to providers based on what kinds of various measures, but including some process and also some outcome of care measures as well. Not paying for hospital-acquired conditions that were not present on admission. So again, forcing a look at a number of different areas of nosocomial infections, of patient falls with injuries, a few other things like that. As many of you know, a more recent program of basically not paying, of exacting a penalty when patients are readmitted within a 30-day window. So again, this idea that's inherent there is paying for quality and looking at shifting some of those financial incentives by putting basically a financial reward on higher quality care as it's measured. Changing that payment structure, and essentially that's what was called for in that article that I mentioned, to create that business case for quality, or at least to strengthen it. But but one important point, you can tell it's important because it's in red and growing. Maybe it's a reminder to me. But one important point in this is that, again, with many quality outcomes, you may not be able to identify a link to any significant or immediate cost savings. So what this government program, and now what many private payers have adopted, is basically manipulating, I don't say that necessarily in a bad sense, but manipulating the payment system to make them financially attractive. And I think one point just to bring home in that is that while we can look at the inherent value in, let's say, preventing a patient fall or in improving a patient's experience of care, and you could even make some generalizations that would probably be accurate about why there's a financial reward, in a sense, an economic payoff in improving a patient's experience of care. It's hard to put that in concrete terms and hard to measure it. And so that sense that these don't necessarily have an inherent sort of demonstrated economic value. So again, while there's a cost savings linked to it or a financial reward, it's basically as a result of a policy decision to say these are the outcomes that we, but Medicare in this case, we want to target, and so we're going to make there be a cost savings or a financial reward attached to this, whether the data can demonstrate that it's inherent to that outcome or not. So one of the things to think about then is how that impacts nursing. And potentially, and I think some health systems have found this, there's an incentive to improve nursing staffing, and I sort of say that in the broad sense. So in terms of numbers, but also education levels of staff, use of specialists to be able to help support decision-making, support practice by nurses in providing patient care. And the idea, again, if you're investing in nursing to improving outcomes and seeing a financial return, then again, there's a strong argument for improving how nursing care is delivered. On the other hand, the downside of that could be, and I think this has happened in at least some institutions, that if those outcomes don't go well, of sort of turning around and saying, well, nursing, you're the ones that keep telling us that you're the ones that are going to deliver on improving patient care in all these spheres, and if it doesn't happen, then it must be something you're doing wrong, and if this cuts our reimbursement, maybe we need to look at reducing staffing or staffing in a different way. So I mean, there's two different ways that can play out. But when we talk about nursing enhancing value and economic, well, specifically economic, why does that happen? What is it that nurses do? And I don't pretend that this is a comprehensive list, but when you look at what nurses really in any area of practice do in terms of ongoing assessment of patients, of monitoring, of knowing when things are going wrong, often before they actually do go wrong, of applying critical thinking in terms of what's being done for a patient, what kinds of interventions are used, when not to use those interventions, educating patients and families, a focus on patient safety, a focus on communication both among nursing staff, among our peers, with other colleagues, with other stakeholders within that system, coordinating care, accurate record keeping, and someday I'll explain why I don't always use the word documentation. I think broader than that, but all of these that I think nurses in any sphere are doing, and again, advocating for patients. If you look at what your specialty does, what your specialty brings to patient care, broadly speaking, I would say it's all of the above, and again, not a comprehensive list, but all of those functions that I think are common to all of nursing, but as I say, plus. I think they take on even more significance that those things be done right, because the consequences of not doing them right have so much of a broader impact and really take on even more importance. So with your specific focus on clinical research, on care of subjects, coordination of trials, supporting the integrity of that, being, as I said, a key part of that research enterprise, of those efforts to generate knowledge about patient care and about new interventions. The outcomes of what you do are far-reaching. Certainly what you do with patients has an immediate impact in terms of patient care, the quality of their care, preventing adverse events, but also affect patients into the future. The interventions that you're working to demonstrate, to try in terms of clinical trials, when successful, have a huge impact on what happens to patients 5, 10, 20, and 30 years from now. That's an important distinction, and I think it again makes part of what makes all of this that much more important, more significant for what you do. So then in looking at the value of your specialty, and forgive my, it's an addiction in terms of I just need to quit PowerPoint cold turkey at some point, but just haven't been able to. So when you look at maintaining the integrity of a study, that's important for what it is, but again, as you know much better than I do, what the implications are if something is done wrong, if a protocol isn't followed, and the impact that may have, very well may have, on the individual patients that are involved in that, but also in terms of what that means for whether and how that study continues, how much time and effort and patient care may have been wasted if something goes wrong. So again, the consequences of that. Avoiding adverse events. Considering what you often work with in terms of new or experimental treatments where sort of the risks are not always completely known. Potentially, the impact on patients of things going wrong can be magnified that much. Decreasing the legal and financial risk for your institutions, for the sponsors of the studies, again, an important aspect of that. And the costs of not complying. So the importance of sort of your heightened understanding of regulations, of regulatory requirements, because of what the impact of non-compliance will be. So again, perhaps losing much of the investment that's been put in a study, the resources in terms of just paperwork alone of addressing that, but also just, again, how that can set back the research that you're involved in, as well as the potential impact on patients. Protecting informed consent, I'll say more about that in just a second, but also the whole idea of safeguarding the trust of patients, both those that are involved in the studies that you're involved in, but also future patients, people's willingness to participate in clinical trials, that basically if things, if their rights, if their dignity aren't protected appropriately, the impact of that, the consequences of that go far beyond, as important as they are, to that individual patient or group of patients. But many of you know this well, that how the community perceives the work that's going on, how people will view what you do, whether they trust you, whether they're willing to participate, and including, I think, both the community as a whole, but including sort of many vulnerable populations. And if people feel, again, that they cannot trust, that they can't feel safe and comfortable with what's going on, then that has a major impact on the kinds of work that can go forward, the kind of, the willingness, as I said, the partnership with individuals to participate in those. So I think all of those being very important. Another side of this, though, I think, in looking at the value that you bring, is also the value that you bring to nursing as a profession. So within clinical practice, the work that many of you do, those that are involved in direct patient care of patients in trials, is the experience that you bring with new treatments, if they come to market, if they come to be accepted practice, that you're going to be the first people who have already had experience with those, that can address what some of the benefits, what the risks are, what concerns may come up for patients, what kinds of side effects or other complications to be aware of. And again, to me, that's a resource that I think is not widely enough recognized, but that, you know, we go forward with a new medication, device, treatment, whatever it might be, and we should know that there are nurses that already have some expertise that can be tapped and can be disseminated on that. What you do involves balancing a number of different priorities, a number of different interests, stakeholders, and you have to do that in a sense while being aware of those interests, sort of respectful of those interests, but doing it in a way that keeps patients at the front, that focuses on patient care, patient protection, patient safety. And again, I think there are important lessons there for nursing as a whole, because I think nurses in any setting are more and more faced with a similar need to balance. As hospitals, other health systems, other healthcare providers more and more need to be looking at cost and how they allocate resources, looking at how they deal with payers. Again, that sense of how to balance, how to be aware and sort of serve multiple interests while, as I said, balancing and keeping patients in the forefront. Again, I think that's experience that you have that's definitely widely applicable to what nursing as a whole needs to be doing and needs to be aware of. One of these things, we were talking about this with Liza earlier, but looking at informed consent, as you need to do, as an ongoing process, not just a form to be signed, not just a piece of paper, or I guess in your case, multiple pieces of paper to be read and signed, but really being sure that patients understand benefits and risks, not just at the start, but throughout their course, throughout their participation, throughout their course of treatment. And this happens to be a pet peeve of mine, and maybe in this case I'm speaking to the converted, but again, I think the experience that you have in dealing with informed consent in that broader sense of ensuring or trying to ensure that patients know what they're participating in, that they continue to be educated, they continue to have their questions answered, that's critical. And again, an area where I think you have significant experience that really can benefit the profession as a whole. Integrating care and research, as we look more and more and emphasize more and more the idea of evidence-based practice, how you integrate both of those. Again, you navigate in your practices in both worlds, and again, that becomes important. Obviously, the key role that you play in any successful research that goes on in those areas. Care coordination being another area where more and more within healthcare we emphasize that the need to do that, of working with multiple disciplines, multiple stakeholders, again, keeping a focus on the patient and what's happening with the patient. Again, not new territory for you, and I think again an area where what your experiences have immense significance for the profession as a whole. So again, with this idea of demonstrating economic value, as I've said, with some contributions that can be done in terms of identifying, quantifying where that value is. Once again, as I've said, putting that in context, looking at social value as really part of the profession's core in terms of its focus on care, on compassion, on advancing health. And again, I probably said it for 17 times in different ways, but that economic value can support that core and can support that in a very important and fundamental way, but should never be allowed to replace it. That should never be seen as the goal of care. It's a support for those goals. As I noted earlier, and again, my PowerPoint addiction comes through, but as I said, in a healthcare system increasingly focused on cost, what nurses do is a humanizing factor. That's key for all of nursing, for what you do in terms of a focus on patients and a focus on what happens to them, on emphasizing care, emphasizing quality, emphasizing patient protection. Again, I think a critical role, critical value and resource that you bring to the profession as a whole. And with that, I will, first of all, thank you for, I think most of you stayed awake through all of this. And again, to thank you, I think, for the work that you do and really my hope for a very successful conference. I really am very excited by the work that you're doing and really has signaled to me the importance of heightening the significance and the visibility of what you do, because as I've said, I think that what you bring in terms of your expertise, your experience, has so much fundamental significance to what nursing needs to be doing, what nursing needs to be knowing right now. And with that, I'll stop, and I think there's a little bit of time.
Perhaps I missed it, but in terms of the value of clinical research nurses in patient care, the one aspect that I didn't hear was value in terms of the quality of the data, and the data then being able to drive future improvement in healthcare. And I think that in terms of an economic factor, is a huge one.
I think that's an important point, and I think what I'll accept as a valid criticism is that I didn't make that explicit enough. I think it was intended in a few of the points that I made, but I appreciate bringing that out, bringing that to the fore. I think that's absolutely true and very important.
Yes, yeah, wonderful talk. Thank you so much. Kind of put a lot of what we're working on in context. And I'm going back to the beginning where you were talking about evidence being built for nursing's impact in general patient care. And where we are right now is facing the same absolute lack of evidence, and also lack of even knowing where our people are, because so many of them are embedded not in traditional healthcare systems, but in all the various organizations that produce research. And so any thoughts on sort of jump-starting that process, because so much of that's big research, which we have no resources for.
I think part of it is doing what you're doing now in terms of building this organization, continuing to solidify your identity as a specialty. And I think as you continue to recruit, and certainly putting more, I don't want to say putting more emphasis, but putting emphasis on outreach to nurses in many places where you may not be as visible as an organization now. And I can't speak to that because I don't know the specific outreach that you've done, but I think that's an important point. I think also as you continue to do that, one thing to do is to look at academic institutions where there are people interested in research on nursing and outcomes, and sort of to look at potential partnerships and to say, you know, there's a real lack in the literature, there's a real lack in research, and to look, I mean, I think it's challenging in any field of nursing to say, well, what are the outcomes that you want to look at? But I think that's the task, and that's one of the reasons why there isn't a lot of concrete research. So I think it is, to some extent, partnering with people that really, you know, have a lot of expertise in doing that kind of research and saying, you know, where can we work with you? And again, to me, a lot of this is taking what I think you all know, I think what you've come to understand and what you've started to explain to the rest of us, of sort of who you are in terms of where you fit in research, and of, even though most of you are not researchers as such, you have a key understanding of that, and an understanding of research as a group enterprise, as a team process. So I think taking that attitude and that approach in working with some of the researchers out there that have fairly solid expertise in looking at outcomes, and looking at sort of adding your expertise in that practice, in that field, and then really exploring how to go about doing that.
You know what might be good, just because we do have one mic, I'm going to go ahead and give this to Catherine here, but if folks could maybe come over by the door, and I can just go back and forth between the door if you have questions.
Again, thank you for the great presentation. That was really awesome. You touched on so many things. The one point that I just want to bring up, and it's just an area that I live in. I actually work in an academic institution. I work at MIT. So I am the only nurse there that does research. I'm it. And that's a problem as far as trying to identify the value of my role with your non-traditional researcher. And I do not have patients. I have research subjects solely. And so that's a real quandary that I'm in, is trying to develop and define, you know, what, you know, metrics can I use for quality outcomes? You know, prevention is always difficult to prove. It's always difficult to identify. And again, this is in an environment that people, don't work often with humans, and, you know, I am the interface with the humans. So it's just, it's an interesting quandary, in a sense, when not all research subjects are patients, and in fact, one could say many of them are not.
So you're asking maybe what, in that context, some comments of...
If I move down too, so you don't have to keep running up here. First of all, thank you in some ways for that correction. I mean, I know you didn't mean it's a correction, but in terms of the need to speak more broadly and not just look at patients. And I guess my clearest answer is I'm not, I'm not sure. I sort of accept the idea that it's a challenge. And when I say that in many areas it's not always possible to quantify these things, I think that's true, but I still think that's a challenge if you're in an institution, in a setting where you need to demonstrate the value. I also think that when we talk about adverse events or adverse outcomes, it's difficult, and I think it's something that needs to be thought through, and probably by you all. There are significant examples out there of what happens when things go horribly wrong with not maintaining a protocol. I think it's difficult because people don't want to name names and point fingers. So I think, and to me, it's a challenge to be considered of how you might take some of those examples and case studies, if you will, where you might even look at what some of the sequelae were, and perhaps some of them even in economic terms, and draw lessons from that. I don't know, because I think it is sensitive to do that, but I think it's something that needs to be thought about and needs to be considered, obviously in a collegial way, because I think there are lessons to be learned from some of the examples where things have gone wrong, and how to do that in a way that doesn't point fingers, that doesn't make people feel worse than they do already. So again, I think that's a challenge, but I think it's something that maybe on some level needs to be looked at.
I also work in an academic medical center, and my role is specifically to liaise between nursing and the clinical and the study team. My challenge, and I'm wondering, I'm sitting here thinking as you do public policy, is there any utility you think going forward in an association like this, lobbying to make nursing more of a requirement when dealing with studies, that have an extremely high risk for danger to the research subject? Because with funding being reduced considerably, I see, in my institution alone, the tendency to start appointing coordinators who are non-nurses. They may or may not have some kind of a physical science background, but nursing is being pushed aside continuously. And we are also looking at the fact, the reality that institutions bring in huge sums of money, and that is a factor that defines whether or not a study comes to the institution. And they're going to be concerned about getting that contract going, getting that study started, and less so about the person who is going to be conducting the procedures on that study. And it's a major concern for me personally as a nurse, because the ANA does say we have two different roles, nursing and the PIT and the study team, and our role is to protect that subject, and it's becoming increasingly difficult to do that under circumstances like that. Sorry.
So Joy, was your question around maybe what kind of advocacy and policy we might be able to do? Is that, okay.
And I think a starting point needs to be, again, as I've said, quantifying the risks, quantifying the adverse outcomes is sometimes difficult. But I think that's one area to be looking at. And sometimes, even when sort of the hard data isn't there, sometimes anecdotes, although we're not supposed to say that they substitute, but in terms of what policymakers look at, often if there are prominent examples of what has happened when you've had non-nurses, non-professionals in those roles of sort of where things go wrong. Again, it's difficult, I know, to sort of point to examples of where things have gone wrong, but that may, as I said, give some data. I think it would be difficult to just sort of start out with simply advocating a nurse needs to be in this role if there isn't a lot to back that up. Because I mean, and I think this is true in many fields within healthcare, where many people are going to view that as though you're trying to protect your positions, or just it's self-interest. So I think looking at ways to frame that in ways that make clear that it isn't. To some extent, the more you're able to demonstrate what the value is, what adverse events are avoided, that also can make that, even without regulation, make that more apparent to the institutions. But I think, in the long run, as your organization grows and develops, that beginning to look at what areas of advocacy you want to engage in. And again, these are things that it's much more difficult to be doing just as individuals. Now, I'm confident that as an individual you are advocating for this, but within the specific agencies or institutions that you work for, your advocacy role is often somewhat limited. So the more that you have an organization that can do some of that speaking, not be under some of the institutional constraints, the better. But I think, again, it's as your organization grows and matures and you can actually devote some focus in looking at how to formulate those policy priorities. This is, I think, one of the things that you all will need to decide, sort of where you want to go and where your energy should go. And certainly others can work with you and give advice and consult on that. But it is something. It's sort of part of your agenda setting as an organization. That sounded like an evasive answer, but.
So I'm going to, 1 minute. So we're almost done with questions, and so I'm going to invoke facilitator rights. So I can't help but think, certainly with your background in A&A and us as a nursing or nurses first and a specialty, how might we partner other than becoming, trying to get specialty recognition by A&A? What other ways would you recommend that we work with larger nursing organizations such as that to help highlight our role and begin that process of developing our strategy to advocate? Because I really feel like it's going to be a stepwise approach to building our plan for advocacy.
I think one thing to do, now, when I put up that slide that had all the logos of various nursing organizations, it sort of emphasizes in some way that to some extent there's a fair amount of fragmentation with so many nursing organizations. But I do think that the more that there are efforts for groups to find a common agenda, that one of the things you can do is look at where you fit in with that. I think there's a lot of work that's been going on, mainly at state and regional levels, around the Future of Nursing report and different efforts in different states. I would say that where you're in a state where some of those efforts are ongoing and prominent, that as an organization or as a member of the organization to look at ways to get involved in that and get your name out, get the fact that you are an organization, that this is a nursing specialty, and begin to look at some alliances there. And I would say in general, looking at other initiatives that may be going on where there may be some coalition efforts or where nursing organizations are working together. And I do agree, it's important to enhance that visibility, even if it's not an immediate opportunity to sit down and educate people about your role. The fact that you exist and that you are there sort of builds those contacts, builds those alliances. So I would say the opportunities aren't always apparent, but I think there are some out there. And I would say, just on a practical matter, that the work that's going on around implementing the Future of Nursing report probably is one of the most available opportunities right now.
So we are out of time, so if we could thank Dr. Keepnews one more time. Thank you so much.